So today's topic is chronic cough in children, and I'm happy to introduce Dr. Trang Din. She is a pediatric pulmonologist at Stanford Medicine Children's Health who sees outpatients in Palo Alto and our San Francisco sites. She completed her medical degree at David Geffen School of Medicine at UC Los Angeles, and she trained in general pediatrics at UC San Francisco Mission Bay campus. She completed training in pediatric pulmonary at the, Stanford School of Medicine and is interested in general pulmonary medicine. Today, she'll cover the important topic of chronic cough, which is a common issue that is seen in many ambulatory venues, such as pediatrics offices, family medicine visits, and urgent cares. Please welcome Dr. Din.
Thank you so much, Dr. Bru, for the introduction. Like Dr. Bru said, my name is Trang Din. I'm so glad to be here with you all today. Thank you for joining and taking time out of your busy days. I have no disclosures to share. So objectives. After our discussion today, we will have reviewed the expert guidelines for the evaluation of chronic cough in the pediatric population. We will have gone through several different entities that commonly present with chronic cough in children and focusing on the conditions that are first evaluated and managed in the pediatrician's office. We will go through the evaluation and diagnostic pathways for these entities, when to refer to your subspecialist, and the management of these conditions. And I am going to have to say chronic cough many times. Please feel free to let me know if I'm going too fast, going too slow. It's hard to know through Zoom how fast or how slow I'm going. Okay, introduction. So the consensus guidelines from the American College of Chest Physicians define chronic cough in children as lasting over 4 weeks. Of note, these guidelines apply to children 14 years and younger. Adolescents past this age generally have cough physiology more similar to adults. And in adults, chronic cough differs in definition, in etiology, diagnostic approach, and management. It's important to use a pediatric-specific cough protocol or algorithm so that patients with concerning chronic cough can be evaluated in a timely manner. Studies have shown that in children evaluated for chronic cough, about 18 to 30% of these children were found to have a serious underlying lung disease like asthma, foreign body, bronchiectasis. So earlier diagnosis and treatment does improve outcome with less lung damage. As with many medical entities, taking a careful history is important for your chronic cough assessment. Some features to distinguish is normal versus abnormal cough. Cough is a protective mechanism to clear debris from the airway, and in healthy children who are not sick, they can cough up to 11 times a day. What can be more difficult is distinguishing a true chronic cough versus back-to-back viral illness with lingering cough. And finally, if the cough, we have to distinguish between a nonspecific cough versus any specific cough pointers that would suggest at an underlying etiology. Before that 4-week time point, because cough often spontaneously resolve, expert guidelines do not recommend using medications or special investigations, especially for nonspecific cough. So let's talk about those specific cough pointers. The presence of any of these symptoms are suggestive of an underlying etiology to the chronic cough. And aside from findings that would be suggestive of asthma or an isolated wet cough that is suggested of protracted bacterial bronchitis, the presence of any of these other symptoms should prompt further investigations. Symptoms such as hemoptysis, hypoxemia or cyanosis, exertional dyspnea, chest wall deformity, digital clubbing, and this is a 2-pager. So if there's any recurrent pneumonia, recurrent infections, that's concerning for immunodeficiency, or if the recurrent pneumonia occurs in the same areas of the lung, that's concerning for a congenital airway anomaly. If there's systemic symptoms like poor growth, then we have to be concerned about many other things. If there's any hoarse voice or stridor, facial pain or purulent nasal discharge, if the child has other comorbid medical conditions like cardiac or neurodevelopmental abnormalities, that opens the doorway to a variety of different other etiologies, and if there's any chronic lung history or esophageal disease. Hopefully, we will be referring back to table 1 throughout this presentation, so hopefully you've all memorized it during our brief but very meaningful glance. Table 2 lists the classic recognizable cough. So presence of any of these specific cough types points towards a certain diagnosis. For example, your barking or brassy cough is classic in croup or tracheal malacia. There's the paroxysmal whooping cough or pertussis or peripertussis, the staccato cough of chlamydia in infants. It's hard to quantify the most common cause of chronic cough in children because the cough etiology is going to be dependent on setting, age, but in practice, for children under 14 years of age, what we most often see, well, for both age group, is that post-infectious cough is the most common cause of chronic cough in the community. After that, it's for children under 14, it's asthma, protracted bacterial bronchitis, chronic aspiration, airway malacia, bronchiectasis. And for children over 14, so for adolescents, the causes of cough are more likely to be similar in adults with gastroesophageal reflux and upper airway cough syndrome rising to the front. And increasingly, we're seeing more and more functional cough in both groups of children, such as somatic cough or tick cough. So let's start off with a case. With 9-year-old Rumi, you might recognize this character from K-pop Demon Hunters. Of course, as pediatricians, we have to stay current with what our patients are watching for educational purposes. So Rumi, she's 9. She's previously healthy. She's fully immunized. She's coming to your clinic for a dry cough of 5 weeks duration. It was preceded by potentially a cold. Parents report that she's back to her normal self, except for this cough. You ask about specific cough pointers and it's negative. Her respiratory exam today is normal. You've seen her before during periods of illness, and and her lung exam during those periods were also normal. So what are your next steps in evaluation? So the evaluation of chronic cough should be systematic. The American College of Chest Physicians expert panel report first put out child-specific chronic cough diagnostic and management guidelines in 2006. We'll be going through doing a partial review of their 2020 guidelines. This is not a definitive protocol, but is meant to help with clinical judgment and not replace your clinical judgment. In children age over 14, it is suggested that we go by the adult guidelines for chronic cough. So after your history, the guidelines do recommend that after performing a thorough clinical assessment, if the history is consistent with a chronic cough, a chest X-ray and spirometry are reasonable first steps in assessment. These studies are not sensitive, so the absence of abnormalities on chest X-ray, on spirometry does not imply absence of disease, but abnormalities on these assessments are specific. I wanted to say that spirometry might not be available at all institutions, but when it is available, I would recommend doing it with pre and post bronchodilator to help identify obstructive patterns suggestive of asthma. And it is reasonable to try spirometry starting at age 5 to 6 years old, or when children can follow commands like blow out as hard and as fast as you can. Although in real practice, sometimes teenagers and adults can have a lot of difficulty doing spirometry. Okay, so you obtain a chest X-ray, the plain film appears normal. Rumi was able to do a spirometry, you get good data, and the spirometry is normal. What are reasonable next steps in management? So looking at this flow chart, or figure 1 is a flow chart for chronic cough evaluation for children less than 14 years old. The first step is to ask yourself, is there the presence of specific cough pointers? Is there the presence of classic recognizable cough, so table 1 and table 2? Is the chest X-ray abnormal? Is the spirometry abnormal? If the answer to all of this is no, you should assess for any exposure history, for example, exposure to tobacco smoke, other pollutants. I think oftentimes we're doing this during the initial history. Regardless of the etiology of the cough, attention to exacerbating factors is recommended. So addressing tobacco cessation, addressing indoor or outdoor pollution on children's lung health is indisputable. We want to align ourselves also with parents and provide reassurance of any underlying concerns. Maybe they just need reassurance that cough after a virus can last over 4 weeks. So with everything else looking okay, the goal is to provide reassurance and do watchful waiting. This is an appropriate step and first step, and sometimes is an appropriate second step. If any of the answers to questions 1 through 4 is yes, or if there's a presence of any anomaly, then we move on to figure 2. Spoiler alert, we will move on to figure 2 later. Okay, so you do the watchful waiting method, and in 2 weeks, Rumi comes back to your clinic, and there are 3 potential pathways in this flow chart. The first pathway is that the cough is resolved or is resolving. Yay. You want to check in with patients until their cough has completely resolved. The second possibility is that there is persistence of this nonspecific cough. Here you want to discuss with parents some options. You can either continue watchful waiting if everything else again is otherwise normal, and you check back again in 2 weeks and restart this flow. The other option, you can do a trial of therapy with low-dose inhaled steroids. So essentially a trial of asthma management. If we are doing a trial of inhaled therapies, it's very important that caregivers know how to properly administer the inhaled treatment. We want to make sure that this trial of low-dose inhaled corticosteroids is a good and accurate trial. So after parents initiate inhaled corticosteroids, then you want to check in 2 to 4 weeks. It takes about at least 2 weeks of consistent use of inhaled corticosteroids for these medications to have optimal effects. If cough has resolved, then consider the evaluation of asthma. If there are no other signs of asthma, then you can stop the inhaled corticosteroid, and the cough has likely resolved because of time. Now, if the cough has not responded to inhaled corticosteroids, time has passed and it's still there, then what you want to do is review questions 1 and 2. Is there now any specific cough pointers? If so, you go to figure 2. And then this is also a very reasonable time to refer to your friendly neighborhood pulmonologist. And then finally, the third pathway is after you see your patient again in clinic. Now there's presence of specific cough pointers, in which case, again, we go to figure 2. Okay. So luckily, Rumi's cough has resolved at your 2-week follow-up. This is the most common presentation in chronic cough because chronic cough is usually from post-viral cough in the community. Studies have shown that 50% of acute cough from respiratory tract infections recover by 10 days, 90% by 3 weeks, but about 10% of acute cough may last over 25 days. Again, this cough is not associated with any specific cough pointers. Okay, we move on to case 2. 5-year-old Mira presents to your office with repeated episodes of prolonged dry cough that the past 2 viral seasons. Parents tell you the cough starts off wet, then becomes dry, and it feels like she's coughing all winter. In the summer, she's well, she's growing and developing normally. She's had some itchy skin patches since infancy. On exam, you hear some expiratory wheezing that clears with Duoneb administration in clinic. You review previous urgent care notes, and there has been noted wheezing in the past. What are your next steps? We go back to our chronic cough flow chart. Given there's presence of specific cough pointers with wheezing, you move on to figure 2, the illustrious figure 2. Okay. So figure 2. Figure 2 is used when there is the presence of abnormal cough pointers. The first differentiating Differentiating path on our flowchart is whether the cough is dry or whether the cough is wet. Going down the dry pathway for our hypothetical patient Mira, we want to consider if there is if the clinical picture is consistent with asthma. Is there the typical respiratory symptoms? Are there signs of reversible airway obstruction or other diagnostic factors? If there is, consider the diagnosis of asthma and start asthma treatment. If no, then it's reasonable to refer to your, again, neighborhood pediatric pulmonologist for the assessment of other entities. We will come back to figure 2, but first let's talk about the presentation and diagnosis of asthma. So asthma is one of the most common chronic medical condition in children. It's a heterogeneous disease with different phenotypes, but it's all characterized by chronic airway inflammation. One way to type asthma is by intermittent, persistent, and allergic type asthma. Identifying the type of asthma and also the severity of asthma is important for treatment considerations. Contrary to popular belief, there's no strict lower age limit for the diagnosis of asthma. That said, the diagnosis in younger children can be particularly challenging. And for those who are interested, we do have an upcoming webinar in January with Dr. John Mark on the diagnosis of asthma in children under 5. We have a lot of future asthma webinars, actually, so tune in for more fun learning and more CME credits. But there are 2 defining features of asthma. So there is the presence of variable respiratory symptoms, such as a dry cough, wheezing, shortness of breath, and chest tightness, symptoms of which vary over time and severity depending on the type of asthma and exposure to triggers. Common triggers include a viral infection, exercise, cold air, allergen exposure, heightened emotional states like laughing or crying, and others. The other defining feature of asthma is that there is reversibility of airway obstruction, either symptomatic or on spirometric data. Then you have to consider the risk factors for asthma, the presence of which, if your patients have the presence of these risk factors, and that changes your index of suspicion for asthma. Well-established risk factors include the presence of other IgE-mediated conditions such as eczema, environmental allergies, so the atopic triad, a parental history of asthma, significant RSV or rhinovirus illness in the vulnerable time frame before the age of 2. A history of very premature birth is also a significant risk factor. And other risk factors that are mentioned in asthma predictive indexes include patients with food allergies, elevated eosinophils, and wheezing outside of illness. Oftentimes, these children also present with repeated diagnosis of bronchitis or pneumonia. So based on our patient's clinical history, she would fall under the diagnosis of intermittent asthma. I do want to make a note that patients with intermittent asthma can still have very severe exacerbations. Okay. Making the diagnosis of asthma is based on identifying the typical respiratory symptoms that we just reviewed and identifying the reversible airway limitations. This can be done via spirometry, the data of which can show obstruction that is reversible after bronchodilator treatment. I want to note that a normal spirometry does not exclude the diagnosis of asthma, especially in children who have that more intermittent picture and they're doing the spirometry when they're well. If there is limited access to lung function testing or the patient is too young to do reliable spirometry, then we rely more on our clinical history. For example, has there been any presentations where the patient's wheezing or workup breathing improved after bronchodilators? If there has been favorable response to an appropriate trial of asthma treatment, is also an important confirmatory piece of diagnostic evidence. Other evaluations to consider include doing a chest X-ray, especially if the child has not had any chest imaging before, so we can rule out other acute cardiopulmonary conditions. Chest X-ray in asthma oftentimes can be normal, but there are some common signs that we'll talk about. Allergy testing to identify children who have an allergic component contributing to their disease. Children with elevations in IgE in their eosinophils are more likely to go on to develop more persistent asthma. Part of the history is also involves eliminating other diagnoses that may mimic asthma. The presence of any of these other symptoms should prompt further diagnostic considerations beyond asthma. This includes symptoms that are present from birth, frequent wet cough, poor growth, dysphagia, inspiratory stridor, symptoms worse after feeding, etc. Okay, so we obtained, coming back to our patients, we obtained a chest X-ray and it shows some typical signs in asthma. Again, normal chest X-ray also is very common in asthma. So this chest X-ray shows some signs of peribronchial cuffing. This is a radiographic finding that's caused by airway wall thickening in the hilar region. In this close-up, you can see an example of peribronchial cuffing here. It looks like a little Cheerio. The Cheerio is an airway coming towards you and is distinguishable because the walls have thickened. Peribronchial cuffing can also be seen in acute viral infection. So this is not this is a fairly nonspecific finding. You can also see hyperinflation in children with asthma, and this is a sign that is suggestive of airway obstruction. It's characterized by diaphragmatic flattening. This example image, maybe the diaphragms are moving towards flattening. Luckily, even though she's 5, we're able to get a good quality spirometry with interpretable data. So for asthma, we pay special attention to the forced expiratory volume in 1 second, the FEV1, and the forced vital capacity, the FVC. FEV1 measures how much air a patient can exhale in that first second of a forced exhalation. FVC measures the total volume of air that can be exhaled during a maximal expiratory effort. The FEV1 to FVC ratio represents the percentage of your total lung volume that you can exhale in that first second. And a lower volume or a lower ratio, less than 80%, represents airflow limitations. Improvement in the FEV1 over 12% after albuterol administration suggests reversible obstruction. So after we've made the diagnosis of asthma, let's discuss initiation of asthma management. For patients with intermittent asthma, you can start at step 1. If patients have persistent mild asthma, you can start at step 2. But of note, like I mentioned before, patients with intermittent asthma can have very severe exacerbations. And for patients who present with severe exacerbation, i.e. they were hospitalized, I do start at step 2 of management. So since 2021, the Global Initiative for Asthma Strategies, or GINA, have recommended that asthma should no longer be treated with just short-acting beta agonists alone. So not using albuterol just by itself any longer. As you can see, for the management of for step 1, for intermittent asthma in children 11 years and younger, step 1 management is you want to do a short course of low-dose inhaled corticosteroids whenever albuterol is needed for symptoms. For patients older than 12, it's recommended that their rescue inhaler has both an inhaled corticosteroid component and formoterol. At step 2, we're doing daily inhaled corticosteroids with albuterol as needed for children 11 years and younger. I often see montelukast being added as monotherapy in the community. I wanted to make a note to say that daily inhaled corticosteroid is more effective in improving symptom control and reducing exacerbations than having a leukotriene receptor antagonist monotherapy. But it can be added on as an adjuvant. For patients older than 12, step 2 entails starting low-dose single maintenance and reliever therapy, so SMART therapy. We have a future webinar on smart therapy as well. And yes, I am going to continue promoting our webinar series. But for all children at step 3, when you're considering starting at, you might want to consider starting at step 3 if at the initial presentation, the patient has troublesome asthma symptoms most days, so 4 to 5 days a week, or they're waking up from asthma once or more a week, or they have low lung function. You want to start at step 3. If we're starting at step 3, or if they have failed step 2 and we're moving on to step 3, it's very reasonable to consider a referral to pulmonary at this time. And then sometimes I get questions about step down management. The general recommendation is that once asthma is well controlled for at least 3 months, then you can consider stepping down on that on the daily inhaled corticosteroid management. Okay. So I made a table of commonly prescribed inhaled corticosteroids and the effective low and medium doses based on age. We won't go into this in detail. I just wanted to provide some examples. Of note, only budesonide is FDA approved for use in children 4 years and younger for as an inhaled corticosteroid for asthma. Though in clinical practice, I do often prescribe fluticasone in this age, especially if the child can tolerate having a spacer over their nose and mouth, as meter dose inhaler is much quicker to administer and can be easier for families to use. Okay, we'll move on to case 3. Bobby is a previously healthy 3-year-old child. He's in preschool. He's coming to your clinic because he has had 6 weeks of a rattling cough. This may have been preceded by a cold. He coughs in clinic and you hear this. All right, so this is a multimedia case. I often play this clip for parents when they don't know if their child's cough is dry or wet. So you hear that cough, it's wet. Your exam is normal though, including normal workup breathing. His breath sounds are clear. He has no digital clubbing. You get a chest x-ray, that's also normal. What is the next steps in evaluation and management? So we go back to our chronic cough flowchart. Given that there's presence of that specific cough pointer with the wet cough, we move on to figure 2 again. Coming back to figure 2, the presence of a wet productive cough leads to this divergent pathway on your flowchart. If there is an isolated wet cough.
Sorry to interrupt, Dr. Din. People are asking for you to replay that audio.
Oh, okay.
It cut out.
Oh, it did cut out. Okay. There we go.
Oh, I think the audio's not working.
Oh no, okay.
You'll have to.
This is not multimedia after all. Okay, what I'll do is I'll include the link in the compendium that will come up with the webinar. Okay, back to our flowchart. I'm sorry about that. I was so proud of myself for learning how to add in the audio. Okay, so if the cough is an isolated wet cough, there's no other specific cough pointers, then it's recommended that you actually treat Bobby for protracted bacterial bronchitis, or PBB, with a 2-week course of antibiotics. Some patients do go on to need a 4-week course. Now, if the cough resolves after that 2 or 4-week course of antibiotics, of appropriate antibiotics, then the diagnosis of protracted bacterial bronchitis is cinched. If there is a persistent wet cough after appropriate antibiotic course, then a referral to the pediatric pulmonologist should be made for the evaluation of other entities. Okay, so protracted bacterial bronchitis, it was first described in 2006, and it's now known to be the most common cause of chronic wet cough in young children, particularly children in preschool age and younger. There is the history of the wet cough for over 2 weeks without any other pointers suggestive of an alternative etiology for cough. Um, if you do a chest X-ray, chest X-ray findings are normal or near normal. Maybe there might be some peribronchial changes. If they can do spirometry is also normal. Unfortunately, with this age group, usually you can't do spirometry. And they do not have signs of crackles or wheeze on exam. Those sometimes parents do report a wheeze, but in my clinical experience, it's usually a rattling of secretions that parents are referring to. PBB can certainly coexist with asthma and wheezing, but the cough of PBB does not respond to inhaled treatments. And part of the presentation is that the cough resolves following an appropriate 2 to 4 week of antibiotic regimen. Diagnosis and management of protracted bacterial bronchitis is very important in children. If left untreated, a percentage of these children will go on to develop bronchiectasis at follow-up. Antibiotics choice should target the likely bacterial flora that's present, which includes strep pneumonia, Haemophilus influenza, and Moraxella catarrhalis, or treat to the local antibiotic sensitivities. Now, most commonly, this means a treatment with amoxicillin clavulanate for 2 weeks, but about half of patients will need up to 4 weeks of total antibiotic treatment. For children whose cough does not resolve within that 2 to 4 week window of appropriate antibiotic treatment, we do recommend, whose cough do respond to the appropriate treatment, we recommend that the diagnosis of protracted bacterial bronchitis be made. If the cough does not resolve, if it persists, or a wet cough returns after the 4 weeks of appropriate antibiotics, a referral to your pulmonologist should definitely be made for their assessment of bronchiectasis or other alternative diagnosis of the recurrent wet cough. Just checking how good I'm doing on time. Okay, so that ends our section where we go through the entities that is treated in the pediatric clinic. Now I want to talk about other common causes of chronic cough in children that we may see once the referral to pulmonary is made. Okay, since we just talked about protracted bacterial bronchitis, I wanted to touch on non-cystic fibrosis bronchiectasis. Protracted bacterial bronchitis and bronchiectasis likely resides on a spectrum of suppurative lung diseases. Bronchiectasis is a heterogeneous chronic respiratory condition with many risk factors that contributes to its development, such as genetic conditions, for example, cystic fibrosis, ciliary dyskinesia, systemic causes such as infections or immunodeficiencies, or aspiration, and then also airway structural anomalies that lead to retained pulmonary secretions. Regardless of the underlying cause, the shared pathway leads to a cycle of chronic airway inflammation, mucus hypersecretion, impaired clearance of this mucus, which leads to recurrent bacterial infections that superimpose, and then permanent airway remodeling that causes airway dilation. Bronchiectasis presentation, what you can see is chronic or recurrent wet cough of over 4 weeks. In children who can cough up sputum, there is production of a lot of sputum, but children, usually younger children, swallow their mucus, so it's just a chronic cough, wet cough. You can see incomplete resolution of pneumonia or recurrent pneumonia. There is return of chronic wet cough after antibiotics. There's persistent or recurrent abnormal breath sounds, such as crackles. There can be asthma-like symptoms, but the child's symptoms are not responsive to asthma treatment. There can be unexplained hemoptysis, although this clinical presentation is rare. And then finally, you can see exertional dyspnea, fatigue, digital clubbing, and poor weight gain in more advanced stages of bronchiectasis. Oh, I also wanted to note that the absence of crackles or on-auscultation does not exclude bronchiectasis, and that clubbing and hemoptysis, again, is rarely present. Having bronchiectasis in your differential diagnosis is very important. Bronchiectasis is likely underdiagnosed, and when left untreated, there is progressive lung function decline. So a referral to your pulmonary subspecialist is very much warranted. The diagnosis is based on the clinical features we talked about, and then it's confirmed radiographically with a non-contrast CT chest. The finding on the CT chest is of a bronchoarterial ratio of over 0.8% or 0.8 in ratio. Is confirmatory of bronchiectasis in children. In adults, the ratio is slightly different. Oh, I forgot to add in a CT chest example of bronchiectasis. Maybe I'll include that in my compendium. So the confirmatory finding, again, is based on this abnormal airway dilation. And then with the diagnosis of bronchiectasis, we also undergo a standard set of investigations to assess for any underlying treatable causes of bronchiectasis. For example, is there immunodeficiency? Is there aspiration going on? We do CF testing if the child has not already gone through newborn screening or other testing. The mainstay treatment for bronchiectasis includes doing airway clearance at baseline and an increase in frequency of airway clearance during periods of illness. Treatment of bronchiectasis exacerbations with targeted antibiotics. And then when outpatient treatment fails, these patients are often hospitalized for IV antibiotics and airway clearance done in the hospital. Okay. I did want to talk about upper airway pathologies. Again, this is not, for example, upper airway cough syndrome, chronic rhinosinusitis. Again, this is not a common chronic cough etiology in children 14 years and younger, but in your adolescent and teenagers, definitely think about upper airway pathologies. Upper airway pathologies can be from different etiologies, including allergic and non-allergic causes, for example, tobacco exposure, infection, and chronic sinusitis. And the presentation of upper airway pathologies include the cough honestly can be wet or dry. Oftentimes parents are complaining of a throat clearing cough. Sometimes in your teenagers who are more in tune with their bodies, they can tell you that they feel an abnormal sensation arising from the throat before they have to cough. Oftentimes there's chronic clear nasal drainage, and when you examine the nostril, there's edematous nasal mucosa. There can be the cobblestone appearance of the pharyngeal mucosa from constant irritation from drainage from the nose. And then you can consider an aeroallergen panel to see if there's any environmental allergies that can be detected. The management of upper airway pathologies is usually an empiric approach aimed at treating upper airway cough syndrome due to allergies, rhinosinusitis conditions. So that includes avoidance of allergens if any are detected, or if there is secondhand smoke exposure. And then it's trial of an intranasal steroid. If a trial of intranasal steroid does not lead to resolution of symptoms, then a first-generation antihistamine can be added on. Resolution of cough to allergy management is both therapeutic and diagnostic. In very young children, you also presenting to your clinic, you also want to consider that chronic cough is caused by dysphagia with pulmonary aspiration. Dysphagia is difficulty with uh, coordination of swallow of both of liquid, solids, or both, and this can lead to pulmonary aspiration of foreign materials into the lower airways. There's predisposing factors for dysphagia, which includes any upper airway anomaly, any neurologic delays. Definitely a history of premature birth can lead to the immature coordination of swallow, any neuromuscular disorders, or if there is a history of vocal cord or laryngeal nerve injury, so children who have been intubated, for example. The presentation of dysphagia, normally we're seeing this in infancy, so very young. You can see a chronic cough that can be associated with feeding. We can see silent aspiration as well, so children show no clinical symptoms of coughing despite aspiration. You can see recurrent wheezing in these very young children, and they do not respond to albuterol, or they very poorly respond. You can hear recurrent rhonchi and that's from the increased respiratory mucus. These children oftentimes have recurrent pneumonias from aspiration. The aspiration of foreign materials may even lead to brief, unresolved, unexplained events. And then you can see clinical signs of difficulty swallowing, which includes difficulty sucking. There can be coughing or choking during feeds, pooling of oral secretions during feeds. Oftentimes, these children have to take frequent breaks during feeds. With a chest X-ray, you can see a normal chest X-ray, or you can see those signs of peribronchial coughing and hyperinflation. You can also see diffuse or focal infiltrates, depending on where aspirated materials land. Okay. For the evaluation and management of pulmonary aspiration, if you have an aerodigestive team available, a referral to your aerodigestive team, which is usually a combination of your head, neck, and throat specialist, a pulmonologist, and gastroenterologist. If aerodigestive is not available, then referral to pulmonary is very reasonable. Also, referral to a speech-language pathologist who have experience with diagnosing dysphagia. Usually, what will occur is a video fluoroscopic swallow study, also known as a modified barium swallow study, and this can be diagnostic. Once dysphagia is diagnosed, the goal of treatment is to provide adequate nutritional intake in a safe way with minimal pulmonary aspiration, minimal lung injury. We oftentimes start off with compensatory feeding strategies. For example, start thickening oral liquids, doing certain positional changes that allows for better coordination of swallow, changes to the bottle or the nipple. Sometimes if we are seeing continued dysphagia, signs of dysphagia, continued signs of pulmonary aspiration, or if at initial diagnosis, the dysphagia is very severe, some children do require a temporary or permanent feeding tube. The next entity I wanted to discuss is airway malacia. For example, tracheal malacia, tracheal bronchomalacia, and bronchomalacia. All these airway lesions are characterized by the abnormal collapsibility of airways, which leads to ineffective airway clearance and can contribute to chronic cough. Here is an example of tracheal bronchomalacia on bronchoscopy. A is a normal trachea with sharp rings. In B, this is a characterized by more U-shaped rings, and this posterior membrane is protruding into the central airways. And then finally, C is sign of dynamic collapse or significant airway malacia, with increased plasticity of the membranous portion into the central airways again. Risk factors for airway malacia. So airway malacia can arise congenitally. So think premature infants, children with a history of a tracheoesophageal fistula, or it can be acquired. So in children with a history of intubation, if there's been trauma to that area, if there's been infection, or an extrinsic compression by components such as a vascular anomaly, tumor, a cystic lesion. The presentation of airway malacia, again, generally presents in younger children as malacia does tend to improve with age, although I did just see a patient recently in clinic who had a reported history of airway malacia. He was 9 and still had severe respiratory illnesses. And on bronchoscopy, we saw there were still signs of severe airway malacia. So generally, again, presents in younger children, but um, uh, you can see outliers. Children will have recurrent seal-like bark. Usually the cough is wet if present. There's also exercise-induced cough with airway malacia. You can hear a wheeze, but the wheeze is different from the wheeze of asthma because it's wheezing from central airway obstruction, which is a low pitch and more homophonous. The wheeze is also unchanged or potentially can worsen after the administration of albuterol. There can also be expiratory stridor, especially if the airway malacia is intrathoracic. The stridor can worsen with feeding or when children are agitated or when children are supine. Parents often report rattling respirations, and again, this can be from entrapment of mucus. There can be recurrent lower respiratory tract infections, again from poor mucus movement, and these children are often, when they get respiratory illnesses, illnesses can be severe with slow recovery. In young children, you might see frequent neck hyperextension so that they can overcome their airway obstruction. And then oftentimes with airway malacia, you can see feeding difficulties in young children. Again, if there is suspicion for airway malacia, then you want to refer to your pulmonologist and or your ENT colleague. Direct visualization by bronchoscopy or microdirect laryngoscopy is the gold standard of diagnosis for airway malacia. We also sometimes do dynamic airway imaging. Generally, airway malacia is managed conservatively, again, because malacia does tend to improve with age. If there generally it's considered airway malacia if there is 50% dynamic narrowing in the airway with forced exhalation. The majority of children with symptomatic airway malacia tend to have more severe airway collapse, up to 75%, especially with cough. And in these children, there can be that impaired mucus clearance that we talked about. So generally improves with age. We do conservative management, and while we're waiting for airway structural stability, we generally do start airway clearance in these children. An example regimen for airway clearance in airway malacia can be adjuvant, followed by normal saline or hypertonic saline nebulized, and then chest physiotherapy to help move up pulmonary secretions that is thwarted by that collapsed airway. Again, the administration of a beta agonist like albuterol can worsen airway malacia. The theory is that the tone of the airway is relaxed with albuterol, which leads to a more pliable posterior membrane. So if you see that, then have airway malacia in your differential. These children may need surgical management, although this is generally reserved for the most severe cases, and it also depends on the etiology of the airway malacia. For example, if there's vascular compression, then we're more likely to move on to if there's an external compression, we might have to move on to surgical management. Okay, and then I do think this is, oh, okay. This is the last entity before we stop for questions. So, like I said, anecdotally, we are seeing more and more somatic cough or tick cough in both young children and adolescents. The presentation of somatic cough is characterized by generally a dry cough over 4 weeks, the character of which can be barking or honking in character. Generally, there's absence of cough during sleep, although the intermittent presence of a nighttime cough does not exclude the diagnosis. Sometimes children can have a premonitory sensation that they, like a feeling or urge to cough before they cough. It is also characterized by a cough that is suppressible, distractible, and suggestible. So oftentimes what I see is that before, when I enter the clinic room, the child is not coughing. As soon as I bring up the word cough, the child coughs. There is a higher association with comorbid mental health disorders. For example, we see somatic cough or tick cough more in children with anxiety and depression. And again, this cough does not respond to medical management. The assessment and management for somatic cough in adults and children, we suggest that the diagnosis of this type of cough can only be made after extensive evaluation has been performed. And then once it is diagnosed, so the comprehensive evaluation, which includes a chest X-ray, the spirometry, referral to your pulmonologist, and if the cough is refractory to medical management. Once the diagnosis of somatic cough is made, then the management is generally non-pharmacologic. So you can try, sometimes there's hypnosis available, cognitive behavioral therapy. Sometimes reassurance is enough to help children overcome somatic cough. Oftentimes I'm referring to our biofeedback specialists or psychologists, or even the neurologist for tick cough. Okay, so I'll stop there and see if there were any questions.
Well, thank you, Dr. Din, for that great presentation. Very thorough. In the question answer, under one of the questions, I actually put the DOI for the CHES ERS chronic cough guideline management guidelines for children that Dr. Din had based this talk on for your reference. So, I really appreciate this presentation and really felt like the pearls I heard were that, depending on where a clinician feels like there are in the pathway, is I think the clinicians, it's helpful to make sure that the patients actually get the therapies you intend, right? Like, so for instance, there's been great questions about MDI, and is the patient actually getting the MDI correctly, making sure there's proper spacer technique, and really allowing enough time for the therapy you've chosen to actually work. So, in these guidelines or this algorithm, they suggest treatment for at least 2 weeks before moving on. And as a pediatric pulmonologist, I often see that patients will only use something for a few days or a week and move on thinking that the medicine hasn't worked. And so I think as clinicians out there, people are working so hard to really address the concerns that these families have and really establish rapport and trust. And that's one of the things that the people who work in chronic cough really talk about, is how there's a lot of distress on these families and caregivers when their child has chronic cough. And that portion of the distress should not be dismissed and should be addressed as you're evaluating them. So moving on to questions, there's some great questions here. I guess as you were going through the second case of the dry cough pathway, one of the questions was, why not treat with albuterol only? because the pathway suggests of treatment with inhaled corticosteroid. And the question kind of alluded to that in people with viruses, they can have airway hyper-responsiveness. And so, Dr. Din, do you want to comment about that, about albuterol only as a therapy?
Yeah. So albuterol only treatment is not recommended any longer because albuterol only treatment has been associated with increased risk of exacerbation and lower lung function in asthma. As well, if we're starting off with albuterol only, we're setting a precedence, I think, for families that asthma is predominantly managed by albuterol, which is not. We know that even in intermittent asthma, there is a component of airway inflammation that benefits from seeing inhaled corticosteroids. And inhaled corticosteroids for patients with intermittent asthma can really help preserve lung function, prevent exacerbations. As well, there is a concern that with albuterol-only treatment, this can actually increase airway inflammation if there is improper use of albuterol, and there's a risk for tachyphylaxis. So that can lead to reduced bronchodilator response when albuterol is really needed. So for all these reasons, the GINA guidelines have recommended that even for intermittent, we should have patients see inhaled corticosteroid and albuterol.
Yeah, so one of the other questions I answered was that, if as a clinician you're wondering if there's bronchodilator responsiveness, do that in your clinic. If you see that the person is wheezing in clinic or has tachypnea, you can actually have provider observed responsiveness. Or if you decide to have the family do it at home, follow-up is really important to know if it's effective. And I second Dr. Din that, we really do not recommend albuterol alone anymore, and that it should be paired with anti-inflammatory therapy, inhaled. The other question was about, these children can get back-to-back URIs, and with wet cough, and how do you differentiate that from persistent bacterial bronchitis?
That's a really good question. Oftentimes, what I will see in back-to-back virus is that symptoms are waxing or are waning, and then suddenly another family member is sick, and then the symptoms of the wet cough worsens. So generally, in protracted bacterial bronchitis, you see steady wet cough without that sort of waxing waning component. But it can be quite difficult to differentiate. But yeah, I would say a good history of hey, did your child's symptoms seem to improve and then suddenly worsen? Were there other sick contacts during this time?
Yeah, so there's another question about, are there any cough medicines that you recommend for children over 6 if they have a viral URI? I'm assuming what the question is.
Unfortunately, studies on over-the-counter cough medications have not shown there's been no evidence that over-the-counter cough medications such as Mucinex or dextromethorphan has helped with reduction of acute cough or reduction of symptom duration, and can actually lead to fairly adverse side effects. So when I see patients in clinic, they often ask this, and I tell them I don't want them to waste their money on those medications because they really have not been shown to work in children.
And we are at time, although there's still some great questions there. So thank you very much, Dr. Din, for sharing this today. And, we have 2 websites for our Pediatric Pulmonary Center here at Stanford Children's Health, breathe.stanford.edu, as well as pulmonary.stanfordchildrens.org.